afternoon, everyone. Good afternoon. For those who don't know me, my name is Tamika Payne, and I am the Customer Service Supervisor here at Team Wellness Center. But I know you guys already know me, right? And what I'll be talking to you about today is about ADT, our ADT notifications. Have everyone heard of ADT? Yes? Okay. And can someone tell me what ADT means? What does those acronyms mean? It is? Oh, it sure is. So ADT means admission, discharge, and transfer process. Every day we receive notification of admissions, discharge, and transfers. But my task today is to go into great detail the purpose of us receiving those notifications, why it's important for us to follow up on those notifications. So I'm gonna try my best to explain it to you guys so that we all have a better understanding why and how important these ADTs are. Next slide. So the challenge, behavioral health, this is a challenge for us all, not just for team, not just for the hospitals, but for all the CMHs. It's a challenge engaging our members, trying to keep them out of the hospital. But we've tried, the hospitals are now communicating with the MCPNs so that they are able to provide us with notification of our members who are hospitalized. So with that, without the knowledge of a transitional of care, the need for intervention may be easily missed if we don't have that communication, which results in more expensive course of care. In order to minimize hospital readmissions and reduce the cost of care, a behavioral health provider must be made aware of the changes in the consumer status.
Please dial extension 207, Care Coordinator Boise, extension 207.
A behavioral health provider must be aware of the changes in the consumer status in real time. In particular, the admission, discharge, and transfer of information from facilities the consumer visit must get back to the behavioral health provider, who may then evoke the care team. And who are the care team? You guys are the care teams, yeah. So what happens,
Care Coordinator Jordan to the social lab. Care Coordinator Jordan to the social lab, please. Thank you.
So what happens on our end, the MCPN, which is CareLink or Consumer Link, they receive report, or they pull a report daily from the hospital. They then send the report to the providers, which is who? Us. Which is us. I get the report, quality get the report, and we send the report out to you guys and to your supervisors, okay? But let's look at some definitions. So the admission, discharge, and transfer system is a system that verifies when the individual is admitted to the hospital, released, or transferred between designated hospitals. All hospital utilizes this system in order to organize and help keep track of the patient's records from the onset of admittance to where they are either discharged or transferred from another hospital. So when we get this ADT report, most of the admissions are medical. We may get a few of the psychiatric admissions, but most of the admissions are medical. Next slide. So the admission, discharge, transfer system. So again, ADT is a software application used by the healthcare facilities in the United States. And they use this system to track patients from one point of arrival until their departure by transfer, discharge, or death. So what is the admission stage? So when you hear the word admission, what does that mean to you? Enter in, admission, inpatient. Okay, so the admission stage is where the patient is admitted or visit the hospital. Administration of the hospital must identify who their client is, and other personal information related to the reason why they want to be admitted. The transfer stage. When you hear transfer, what does that mean? Moves one to another place, absolutely. So this is an optional process where the patient can be transferred to another hospital or another facility. The patient can choose to be relocated to another hospital from the current in which they are staying. Patients transfer hospital must transfer the information of the patient's medical records in order to update and file information into the current hospital system. So even if if the hospital is transferring cases, just as we do in our EMR system, we have to make sure that the information, the demographic information and the reason of the member visit, all those things are important, are updated in the system before that member can be transferred. So the discharge stage, what does that mean? You're leaving, or you being discontinued that service, or you leaving the hospital, and that's the last stage. And what happens is a nurse may assess the member. If there's a legal guardian involved, they'll give instructions to that legal guardian as far as any medications, any follow-up appointments that need to be made, those things. And they're also going to confirm the plan for any follow-up or education on appointments. So we get calls to our call center of members, and they may not be just discharged from psychiatry, they may be just discharged for medical reasons, and they need follow-up appointments. Ms. Dorothy?
Good question, and I think I kind of got off when we, of what we were supposed to be doing. So when a person has been discharged from the hospital, and we follow that after hospital care, is for both psychiatric and physical health care.
Yes.
So either one, we focus 100% on the physical health, even as mental health clinicians,
Yes.
as well as the
the physical health.
So if they come in and it's been physical, do we also link them to the psychiatrist, or is it to Dr. Miller or to their PCP or?
Yep, if it's physical, if they were admitted for medical, we want to link them back to their primary care. But we also want to let our psychiatrists know that this member was admitted for medical, especially if it's something that is a new occurrence. The member may find that they have diabetes. We want to communicate that to our psychiatrist so that there could be adjustments made to the person's medications. But for this ADT, it's very important, and that's a good question, Ms. Dorothy, thank you, that we do communicate with the primary care, because that's integration of care. So everyone should know, especially our members, they may forget what medications they were on, or they may forget why they went to the hospital. They may have gone for one reason, but something else occurred. So that's why that communication is very important, that integration is very important. So the solution to this is CareLink has a process that provides a daily summary of consumer activity within an acute care facility. For each partner care coordinating or support coordinating agency. This daily summary is called the ADT notification. It provides a daily list of consumer activity, providing full transparency to the behavioral health provider, enabling them to notify appropriate care team members to respond to potential or immediate situations. I've given you guys a copy of what, yes. Oh, you didn't get one. Okay, thank you. I've given you guys a copy of what our ADT report looks like. And again, this report is sent to us daily. Normally in the morning time we receive this report. The members that are highlighted, I took out the member names for the sake of HIPAA, but the members that are highlighted in yellow are the recent new admits. Those members that are in the pinkish color are members who are discharged. And we're going to go further in the PowerPoint, and it's going to explain which members we are actually reaching out to. We want to reach out to those members who were discharged within 120 days of service, okay? Those that have been discharged in 2014, 2013, you could do a call to them, but we're really looking at those that we recently discharged in 120 days, okay? So the benefits of this notification. ADT messages are beneficial to organize because they allow the care team members and providers to be better informed about their consumers' hospital activities. This notification may trigger an action to be taken to reach out and engage with the member that is transitioning from inpatient care to community care-based care. The intervention can enable the provider to engage with the consumer and assist with the care and services needed that could help divert readmission, prevent care disengagement, and reduce symptoms of, I can't even see that, exasperation? Is that it? Exasperation, because it's cut off a little bit? Yeah. Okay. All right. So the next slide. Why ADT messages? Probably be better for me to read off of this. So why are we receiving these messages? So the ADT messages allow for enhanced access to care. The messages deliver the care teams more information about their consumers' health. The ADT give care teams and providers documentation of their consumers' health status in real time. This will allow the consumer care team and providers to build a stronger relationship by providing the consumer with access to high quality of care. That's that integration. That's that, you letting the doctor know the medical changes that occur with that member. In addition to you letting the doctor know, what must we do as well on the clinical end. So we just found out that the member may have hypertension, or they may have diabetes, or they are and have cancer. What are we doing internally? What we need to do to treatment plan?
Addendum.
We need to do an addendum to that treatment plan, and we need to update the Access 3. The therapist needs to update the Access 3 to include that medical condition of the member.
Also
All
need
right.
a communication with the doctors that are providing the service to that member. Whether it's
Absolutely.
Primary care, the cancer doctor, whatever doctor that's going on, you need to be able to communicate that information so you can have some information update.
Absolutely. So we need to, with the purpose of the ADT, we should be reaching out to the primary care. We must try to reach out to the primary care. Make sure that member have a follow-up appointment. In addition to that, we're asking for the records for that member. So of course you have to have a release of information. So we need any update discharge information or the med list from that medical doctor, okay? So what is our proactive approach in doing this? Again, the care team is going to call the primary care and set up an appointment with the consumer at the time of discharge. This allows the care team to monitor the consumer's condition instead of waiting for the consumer to call in and schedule an appointment themselves. The ADTs may show a pattern of consumers who are frequent users of the hospital. This information allows the care team to be more proactive and take initiatives to reducing unnecessary hospital admissions and emergency visits. Our ADT messages may include the diagnostic information about the admitted consumer. So if you see on that report that I gave you guys a copy of, it'll show what the, can I borrow yours? It'll show why that member was admitted to the hospital. So you see the diagnosis column. You will also see what facility that person was admitted into, the date of admission. Now, the discharge date, you don't always see a discharge date. That's why it's important for us to communicate with the primary care and also reach out to that member. We get this report for both Eastern Market and for Southgate. And then we've included the care coordinator, the therapist, and the last scene. So this information, this is how we're able to identify who is the member's care team, okay? And if there is no diagnosis, that's because the report is coming from the hospital and the hospital didn't input any diagnosis. So we're just basically, we're receiving this information from the DASH system and we just format it in a system that was easy for us to read, but whatever information that's translated on here, we get this from the MCPN, okay? And you receive these ADTs daily. So the first column, that is the member ID number. That is not our medical record number, but you are able to search the member by both numbers. I mean by either the member number or the medical record number. Our responsibility is for admissions and discharges from patient status. We must document the following in the member's chart. So we must document the date that we communicated with the primary care, the result of that conversation with the primary care, and any remaining actions. So the ADT engagement steps on how we are compliant and how we are being tracked and audited. Inpatient admission is to engage the member primary care office and request participation with discharge planning. The inpatient discharges is to engage the member PCP office and request participation in aftercare planning. We must document our efforts. By the telephone contact to the PCP, we must discuss who we spoke with. We could provide a number, and I would even provide the date of that contact. If you had to leave a message with that primary care, who did you leave a message with? And the expectation of compliance or turnaround time, immediately, the provider will engage the PCP immediately within the next business day of the ADT received. So our turnaround time is within 24 hours, we should be reaching out to the primary care. And we will be audited by the MCPN to make sure that we are documenting or trying to make an attempt to engage services for our members. So the provider will document actions within the clinical progress note to identify, review actions taken, if appropriate. The CMH staff will contact the PCP after an ER visit unless the parent had already done so, but we don't have children. If the emergency visit is the result of a chronic condition, it should be included in the IPOS. The member charts. So randomly what happens is CareLink will randomly choose charts, and they will do this quarterly. We don't know what charts they're going to choose, but they randomly choose these, it's probably the frequent flyers. And what they would do is they will ask us for our documentation on follow-up. Okay, have we been reaching out to these members? Have we been trying to re-engage them? So for members, if we've scheduled a primary care appointment, it's up to the case manager, the care coordinator, to follow up with that member. If they miss the appointment, you're going to document why they missed the appointment or try to reschedule them for a future appointment. But all of these attempts must be documented.
The case closed.
If the cases are closed within 120 days of admission or discharge event, a courtesy call to the members is recommended. Any cases closed beyond 120 days of the event may be ignored. So again, any cases that are closed within 120 days, just do a courtesy call to those members. If it's beyond 120 days, then you don't have to worry about those members. Yes?
You said it's up to who to reach out and re-engage the member?
You could do it as a team, but for instance, if you were successful in getting in touch with that member, you scheduled the appointment, then it would be up to the case manager to follow up to make sure that that member attends that appointment. Kathy asked, what if the case was closed? And it's within that 120 days. We still have to make contact because that member is still on our CRISP. Yep, we're still the responsible party. That's why it says 120 days. That member is still on our CRIS. Now, if you contact the member and you find out that that member is receiving services from another provider, you can either let your supervisor know or let myself know. We have a system where we can verify that information, and then we will do what is called the provider change, okay? But but it's up to us to make sure that we are following up and at least verifying or at least reaching out to those members. So how CareLink will audit us, they may do a desk audit, meaning that they're sitting at their computer in their office and they're just looking at, we give them access to our charts and they'll go in and look at our charts to make sure that we are reaching out to these members. Or they will we have to fax over the progress notes to them with the ADT information, or we will have to upload the information to their VPN for them to view, for CareLink to view. And when this audit is done, CareLink must receive the information within 2 business days of request from the provider, or we are considered as non-compliant. So here, and it's in your PowerPoint, and I could, if you can't see it, I can email it to you. But here's a sample of documentation, and I want to thank Darlene for providing this to us, and this was last year. But this is just a sample of how you could document your contact with the members, okay? So you don't have to use this. You could use your own format, but just make sure that it's so important. These ADTs are so important, as with everything else, but we have to make sure that we are following up on these ADTs, because again, we could be audited at any time. And also the re-engagement team.
Excuse me, you can send it to us.
Yep, I can send this to you in an email.
Yeah, I need it too.
Okay, yep, and then also the re-engagement team is available to assist. I have them reaching out to those discharged individuals mainly, but if the member is still active, I would ask that the care team make some kind of connection. You have to make connection with the member as well as with the primary care.
When we say care team, it could be the peer support.
It could be the therapist.
It could be or the therapist. So we don't want to put the onus on the care coordinator, we don't put the onus on the therapist, we don't want to put it on the peer support. But it's a collaborative effort, you guys are a team, so whoever the best person is, then that's where we're asking to reach out and try to re-engage the member or do the
Are there any questions? Did I go too fast? Yes, ma'am.
I have a member that goes in and out the hospital literally every week.
Okay.
So, he brings the discharge papers. I order them from Harper Hospital and I never get them back, if he doesn't bring them.
Okay.
So how do we, do that, deal with that?
So what are we doing to prevent the member from going in and out of the hospital?
The therapists have talked to him, we both have talked to him together, it's just his mental.
And this is for psychiatric?
He goes for psychiatric, he goes for medical, he'll go from one hospital to the other, it's actually to get medicated.
Is he homeless?
No, he's not homeless. And just last week I took him to detox and he didn't stay, but he's in that habit of going to the hospital. We've tried intervention.
Do he have a primary care physician? And you make communication to that primary care physician?
I made communication with the primary care.
Okay.
But maybe I need to.
Yes.
But, every week he's in the hospital.
Yeah, so you may want to reach out to that primary care, and then you guys probably need to sit as a team and really, really find out what is the root cause. What is causing this individual to keep going to the hospital?
To get this medication, that we don't give. But it's every day.
Well, isn't that what the maps is for? If he go from one hospital to another, and they go and look into that map and see that he's getting that medication from one hospital, they won't give it to him from the next hospital.
Yeah, but we gotta talk. you know, you gotta talk to the psychiatrist. So when he come in for his med reviews, you probably have to go into his med reviews with the doctor. That's that integration. You all have to talk, you know, with the different doctors and one another.
I'm not getting the ADT report daily.
Because your supervisor should email it, because what happens is it comes straight to management. Management, we were actually sorted through contacting the care coordinators, hey, member has been hospitalized, please follow up. But what happened within the past recent weeks, the supervisors, for no concern, I emailed them to my team directly now saying, please review this list, follow up, so you guys can see if you have any members on it. But it does not come to the care coordinators. You may want to talk to your supervisor and say, hey, can you start forwarding us to ADT, because it comes to the supervisors first.
Okay.
So if the supervisor gets kind of backlogged, they may forget to send it to you, but I know that I send mine to my staff so that they can review the list to see if they have in fact any members, because it's so time consuming for us to have to review the list to see who you have and then still send you an email to say follow up. So just mention to your supervisor you want to be sent the ADT report.
Okay.
I think I did send one today to the CCs. Is it EM-CC?
Yeah, but it's so hard for you.
Yeah.
And,
So, but in the interim, it is sent to the supervisors. Okay. So three things to remember. Documentation is very, very key. Again, that follow-up with the primary care, that follow-up even with your member is very, very important. And we have to document everything, because if we don't document it, it didn't what? It didn't happen. Engaging the primary care, because we are looking at the integration of care. Any other questions? Do you have a better understanding of what ADT is and how important it is? You do? Well, I want to thank you all.